Okay, so I think now would be a good time to start. So I just want to say welcome to everyone for joining us today on behalf of the GloDerm Training Committee. So welcome to one of our webinars. And today's talk is going to be very interesting. It's on paediatric dermatology and it's by Dr. Rohit Kothari, and he's an assistant professor in India, and his trainee, Dr. Karthi Kishore. So moving on. So your meeting hosts today are myself. So I'm Emily Vaughan and I'm a UK dermatology registrar. And my co-host today is Dr. Iche Ujile, and she's based in Nigeria. So I'm sure many of you have attended a GloDerm Training Committee webinar in the past, but for those of you that are new, welcome. And GloDerm is an international alliance for global health dermatology, and our aim is to promote knowledge equity by improving access to education for dermatology trainees and those interested in dermatology around the world. And we aim to provide free educational events and opportunities to build networks and collaborate with doctors from around the world. So before we start, as a few more people are trickling in, what can we expect in the upcoming months? So we've got a few exciting webinars coming up. And so on November 25th, we've got a webinar about the new frontiers in the treatment of acne. And then on December the 1st, we've got Dr. Lebwell from New York and Dr. Coulson from the UK, and they're presenting their most interesting cases. And then on December 18th, we have a webinar on neglected tropical diseases, and it's titled Global and Grassroots Efforts Towards Skin Neglected Tropical Diseases, How Can We Contribute? So that's just a little bit about what to expect this year. So a little bit of housekeeping. Your audio will be muted and your camera will be switched off during the webinar, and that's to ensure that there aren't any distractions. And if you have any questions or comments, please share them in the chat function, and our meeting host will collate these and present them to the speakers at the end of the webinar. And also feel free to put your name and where you're from in the chat box so that we know who's attending today. We'll also be sharing some information about the GloDerm Training Committee and the future webinars in the chat, so do keep an eye out. So on to our speakers. So we've got Dr. Rohit Kothari, and he's an alumni of the prestigious Armed Forces Medical College in India. He's currently working as an assistant professor in dermatology in the Tertiary Care Hospital in Bangalore. He's got a special interest in clinical dermatology, dermoscopy, infections, and research. He has more than 30 PubMed national and international publications to his name, and he's also received scholarships from the British Association of Dermatology and the European Academy of Dermatology and Venereology in order to present his work at the annual conferences. He's currently working on various projects on psoriasis, paediatric dermatology, and pigmentary disorders. He's passionate about providing accessible, equal, and enhanced skincare to all patients. And then his trainee, Dr. Karthi Kishore, a bit of information about her. So she's currently doing her residency program in dermatology in Bangalore, and she has 4 international publications to her name. Her areas of interest are clinical dermatology, paediatric dermatology, and dermatosurgery. She's received various scholarships from the Indian Association of Dermatology, Venereology, and Leprosy. And she also pursued her MBBS from the Armed Forces Medical College in India. She initially worked as a general physician, where she was involved in providing medical aid to patients in remote and conflicted areas of the country. So without further ado, I will hand over to Dr. Karthi Kishore. So I will stop sharing my screen.
Am I audible?
Yeah, that's brilliant. We can see you and we can hear you. Go ahead.
Yeah. Thank you, Emily, for the kind introduction. Good evening, everyone. Greetings from India. I would like to start the session on pediatric dermatology, few interesting cases which we have seen in our center. We have no conflict of interest to declare. I would like to extend my thanks to the Department of Pediatrics and Pathology from Command Hospital, Bangalore, for their kind support and cooperation. Moving on to the first case. Our patient was a 5-year-old child, a third product of a non-consanguineous marriage, a resident of Bangalore, India, with informant father and reliability fair. He presented to us with complaints of multiple pustular lesions and ulcers present over the body for the past 3.5 months. Patient was apparently asymptomatic 3.5 months back when she initially developed a pustule over the right ankle, which had increased to twice of its size over the next 2 to 3 days, which were of sago grain sized. She also gave history of similar lesions, which had started appearing gradually, which initially started on her right ankle, proceeded over to the left ankle and both legs and thighs, associated with pain and itching, which had ulcerated over a period of a week. There was also associated history of pus formation over the next 1 to 1.5 months. There was a history of similar episode 1 year back, which was managed at a local hospital. However, documents weren't available. There was also a history of fever of 10 days, which was low grade, intermittent in nature, which were relieved with oral antipyretics. There was history of difficulty in weight bearing due to the pain. There was no history of joint pain, abdomen, diarrhea, recurrent respiratory infection, sinusitis, epistaxis, cough, photosensitivity, oral ulcers, skin tightening, dryness of eyes or mouth, Reynolds phenomenon, proximal muscle weakness, weight loss, night sweats, and anorexia. We had placed our differential diagnosis in the lines of ANCA-associated vasculitis, medium vessel vasculitis, undifferentiated connective tissue disease, pustular pyoderma gangrenosum, ulcerative cutaneous plasmacytoma, atypical mycobacterial infection, and papillonecrotic tuberculate, though they were less likely considering the recurrence of the lesion. On general examination, the temperature was afebrile. The child was tachycardic with a pulse of 102 per minute. Respiratory was 22 per minute, SpO2 98% in room air. Pallor was present and inguinal lymphadenopathy was present. The rest of the systemic examination was essentially normal. On dermatological examination, the child had presented with multiple well-defined, discrete, crusted papules and few pustules, which were distributed over the extensor and flexor aspect of both the lower limbs, as we can see in this image. And she had also developed pustule at the site of her venipuncture, and there was also an erythematous papule, which had developed over her right hand at the site of the PPD injection. On investigation, she appeared to be anemic with a raised TLC count, and the platelet, there was a reactive thrombocytosis and elevated inflammatory markers in the form of CRP and ESR. Rest of the other investigations were normal. On peripheral blood examination, there was normocytic normochromic anemia with neutrophilic leukocytosis and presence of thrombocytosis. A pus swab was taken from the lesion, which on staining revealed gram-positive cocci in pairs and clusters, and on culture sensitivity revealed Staph aureus. Blood, urine culture, chest X-ray, USG KUB was within normal limits. The tumor markers and tissue cultures were negative. We had taken a biopsy from the lesion over her right leg, and we were able to see presence of dense inflammatory infiltrate, which was predominantly consisting of neutrophils present over the superficial dermis. There was also a presence of leukocytoclastic vasculitis with karyorrhexis, which can be seen through the red arrows. However, there was no granular or any atypical cells which were seen. So the picture was mostly favoring that of pyoderma gangrenosum. So we came up with the diagnosis of pustular pyoderma gangrenosum. We had started the patient on an antibiotic cover with injection augmentin and gentamicin, and she was also started on syrup prednisolone initially at the rate of 1 mg per kg over 7 days, which was tapered over the next 21 days and finally stopped. And we had given local potassium permanganate soaks twice daily for the lesions over the leg, and also topical application of 2% mupirocin ointment. However, the patient did not come for any in-person review because we had asked her to review only in case of any fresh lesions, but she was still kept on a telephonic follow-up for the next 9 months. Moving on to case 2. Our patient was a 5-year-old male child, a second product of a non-consanguineous marriage, informant mother and reliability good. He had presented to us with complaints of a red rash over the face, hand, and feet over a period of 15 days, associated with weakness over both the upper and the lower limbs for 10 days. Patient was apparently asymptomatic 15 days back when he had initially developed a red flat rash, initially over the face, which had progressed to involve both the upper arms and legs for 2 days. And he also developed multiple skin-colored red raised lesions over the back of fingers, elbows, and knee. It was, however, associated with itching, which had increased on sun exposure. The patient had developed 10 days back a difficulty in standing up from the squatting position, getting up from lying position, getting onto bed on his own, lifting his hands above the shoulders, holding objects for a prolonged period of time, and difficulty in walking. There was no history of fever, joint pain, swelling, oral ulcers, difficulty in opening the mouth, tightness of skin, bluish discoloration of the extremities on exposure to cold, dry mouth, and dry eyes. There was also no history of gastroenteritis prior to the episode of weakness, recent immunization, drug intake, travel, or exposure to a COVID suspect or a confirmed COVID case or any COVID-like illness. There was no history of difficulty in breathing, cough, chest pain, palpitation, dysphagia, vomiting, loose stools, fecal urinary incontinence, weight loss, and night sweats. The other history, past history and personal history, was not significant. A developmental history, all milestones were attained as per the age, and family history and treatment history was not significant. On general examination, the vitals were essentially normal. There was no paler icterus, clubbing, cyanosis, and lymphadenopathy. On general examination, the head-to-toe examination of the child did not reveal any features suggestive of either facial dysmorphism or any abnormality associated with any congenital disorder. Anthropometric parameters were essentially appropriate for his age and gender. Systemic examination, the respiratory system, CVS, abdomen, and the nervous system examination, they were essentially normal. Moving on to the reflexes, the superficial and the deep tendon reflexes were also within normal. And moving on to the musculoskeletal system, the shoulder, hip, and the knee group of muscles, they had shown a decreased PAR of 3+. The other group of muscles, they had a normal PAR. The systemic examination, the tone bulk of the muscles, they were normal in all 4 limbs, and there were no signs of involuntary movement or fasciculation. Moving on to the dermatological examination, as we can see, there was presence of multiple well-defined, discrete to coalescing erythematous papules, which were distributed over the dorsum of both hands, over the proximal interphalangeal joint, suggestive of Gottrin's papules. There was presence of well-defined, discrete erythematous papules, which were distributed over the extensor aspect of both the elbows and the knees, suggestive of Gottrin's sign. There was also presence of similar skin color to erythematous papules, which were present over the inner aspect of the fingers of the upper limb, which was suggestive of inverse Gottrin papules. And we could also notice presence of erythematous to violaceous macules with areas of hyperpigmentation, which were distributed over the extensor aspect of all 4 extremities, suggestive of confluent macular violaceous erythema. On nail fold capilloscopic examination, there were presence of dilated nail fold capillaries, presence of splinter hemorrhages, rack cuticles, and areas of capillary dropouts were noticed. There was also presence of a faint erythematous rash, which could be appreciated over both the upper eyelids, suggestive of an early heliotropic rash. So we came up with the differentials of juvenile dermatomyositis and overlap syndrome. However, considering the symptoms of the patient, Guillain-Barré syndrome and motor neuron disease were also kept as DD by the pediatric team. Moving on to the investigations, the creatinine phosphokinase levels were elevated. ANA by IF and myositis profile, they were negative, and the SARS-CoV-2 IgG antibody level were positive. Moving on to the electromyography. The electromyography did reveal spontaneous fibrillations and small polyphasic motor units with an early recruitment, which was highly suggestive of an underlying myopathy. And we had done MRI of the lower limbs, which did show presence of hyperintensity on T2 and stir sequences. There was diffuse, symmetrical, extensive muscle edema, which was noticed with underlying myositis, as we can see in this image. The other investigations, the ECG did show a first-degree AV block. Apart from that, chest X-ray, PA view, ultrasound abdomen, pelvis, and 2D echoes were within normal. And the other relevant investigation, only the liver enzymes, AST and ALT, were elevated. Apart from that, the other hematological and biochemical parameters were more or less within normal limits. These were the investigations, and even the viral markers were negative. So as per the Bohan and Peter classification, the patient did fulfill the criteria as highlighted here of symmetrical proximal muscle weakness, elevation in serum skeletal muscle enzymes, a characteristic electromyography pattern of myositis, and a typical rash of dermatomyositis. So satisfying the criteria, we did diagnose the patient as a case of a juvenile dermatomyositis, probably triggered due to an underlying COVID infection, subclinical. So the patient was started on IV methylpred, 25 mg per kg per day for 3 days, and switched on to tablet prednisolone, 1 mg per kg per day, with a gradual tapering, which was done over a period of 6 weeks, followed with adjuvant therapy of tablet methotrexate, 5 mg per kg, which was introduced in the 4th week of therapy. So the topical management was given in the form of a sunscreen of SPF 50, which was given to be applied over the daytime, 0.1% of tacrolimus ointment to be applied at night over the skin lesions, along with twice daily application of emollients in the form of liquid paraffin. The patient was advised sun protection and also physiotherapy. The patient is on regular follow-up. The last follow-up was done at 48th week of therapy when the patient was on methotrexate 5 mg per week. He does not have any cutaneous manifestations as of now, and some amount of post-inflammatory hyperpigmentation is present over all the 4 extremities, and the muscle power has definitely improved to 4+ than his initial condition. Thank you. I would like to call upon Dr. Rohit Kothari to take over the discussion.
Yeah. Can you hear me?
Yes, we can hear you and we can see your screen.
So thank you, Karthi. And at the outset, I would like to thank Load Up Committee, which is a great initiative for improving the dermatology training across the globe, especially in the developing countries. So I'll go ahead with the discussion of the 2 cases. I don't have any conflicts of interest. So firstly, we'll start with the pyoderma gangrenosum, the first case. Pyoderma gangrenosum, it's a neutrophilic dermatosis, which consists of various disorders, which are heterogeneous. However, they can have overlapping histopathological findings, pathogenic mechanism, and also the therapeutic approaches quite overlap in these conditions. And the main defect is altered neutrophil recruitment and activation. So basically neutrophil infiltrate into various organ system, and it's a multi-system condition. So this is just a basic, how does a neutrophil act? Mainly through three mechanisms: degranulation, wherein the granules are, they give out their contents into the surrounding, and it consists of various enzymes like elastases, proteases, which digest the microbe, and then it can act via phagocytosis. So phagocytose the organism and form phagolysosome, which again digest the microbe. And a recent, quite not very recent, but then it's a new concept of netosis, which is neutrophil extracellular traps, wherein the membrane, nuclear membrane of the neutrophil, it dissolutes, and then the chromatin material, it goes outside, and the chromatin material consists of these enzymes, which are the contents of granules like elastases and proteases. Or microbes attaches onto this chromatin material, and these enzymes then thereafter they help in digestion of the microbe. So it's pyoderma gangrenosum is an uncommon condition. It's a chronic and recurrent condition wherein the patient gets ulcers over the body, and it was named pyoderma gangrenosum by Dr. Brunsting in 1930. Predominantly affects females, usually 40 to 70 years of age. So in pediatric age group, pyoderma gangrenosum is not very common. So it almost 30 to 50% of the cases can be associated with multiple conditions. We can remember it by the mnemonic MRI. So M stands for malignancy, which is usually a blood malignancy, hematological malignancy. So, and R stands for rheumatoid arthritis, and I is for inflammatory bowel disease. Most commonly in adults, it's inflammatory bowel disease, and malignancy is quite rare in children. And the specific subtype of pyoderma gangrenosum, which is associated with malignancy, is bullous pyoderma gangrenosum. And then there are certain new syndromes which have been described in association with pyoderma gangrenosum. That is Papa syndrome, PASH, and Papash syndrome. Papa and PASH syndrome, they are autoinflammatory syndromes. So pathogenesis is not completely understood. I'll try to make it simple. So the three broad mechanisms which act in any neutrophilic dermatosis are: firstly, the neutrophil function is abnormal in a genetically predisposed individual, and the individual also has altered expression of the inflammatory molecules. So we'll see them one by one. So the abnormal neutrophil function can be any function of the neutrophil can be abnormal, like chemotaxis, migration, phagocytosis, killing of the bacteria. These all, either of these function can be abnormal, which may predispose to neutrophilic dermatosis. And then there is also elevated granulocyte colony stimulating factor, GCSF. The main function of GCSF is to increase the production and differentiation of neutrophils. So it is overexpressed in cases who are predisposed to neutrophilic dermatosis. Genetic predisposition is mainly described in association with the Papa and PASH syndrome, which are autoinflammatory syndrome, various combination of pyogenic arthritis, acne, and hidradenitis suppurativa. So one gene which we have to remember is PSTP-IP1. This is the most common gene which is impaired in Papa syndrome and PASH syndrome. Then altered expression of molecules is most important is interleukin-8. Interleukin-8 is mainly concerned with recruitment of neutrophils. So it is overexpressed in cases which leads to increased recruitment of neutrophils. And others can be interleukin-17, TNF-alpha, then chemokines 1, 2, 3. These are also involved in recruitment of neutrophils. And then the matrix metalloproteinases 9 and 10, which are also involved in neutrophil recruitment. There's also a concept of autoinflammation because there is increased amount of interleukin-1 beta, which is seen in these patients. So that suggests a role of autoinflammation, that is an overactivation of your innate immunity. That is through inflammasome creation. So inflammasomes are nothing but these are protein complexes which are present inside the cytoplasm of our cell. So what they do is they identify something known as PAMP, that is pathogen associated molecular pattern. So they identify it, leads to activation of caspase, which in turn increases interleukin-1 beta. So these inflammasome, they're specifically implicated in autoinflammatory syndrome. And then there is also overexpression of interleukin-23, which increases the expansion of Th17, which produces interleukin-17. Lethargy is seen in almost 20 to 30% of the cases of neutrophilic dermatosis. It's a non-specific hypersensitivity reaction to skin trauma. So how do we do it is basically we take 0.1 ml of normal saline and we take 20 gauge needle. And two things to note here is we cannot do it with a insulin syringe, which is around 30 gauge needle, because using a smaller needle size may lead to falsely negative pathology. And then we don't have to disinfect the skin prior to doing pathology. Again, the exact reason is not known, but then it may lead to falsely negative pathology test. So 20 gauge needle and without prior disinfection of the skin, we go at an angle of 30 to 45 degree and we go around 1.5 to 2 mm deep. And a positive test is you'll invariably find a papule developing at the site of puncture. But then if it is more than 2 mm papule, then it is positive. Or if the patient developed pustule, like in our case, at the site of Montu test where we had done purified protein derivative, we have injected PPD. At that site, the patient developed a pustule and a surrounding erythema. So it is nothing but the trauma triggered an aberrant inflammatory response that led to this particular kind of lesion. So pyoderma gangrenosum is mostly almost 70% of the cases will find on legs in adults. In pediatric age group, you may find it over the perianal and the genital region. That is a difference. And then initially, the patient will develop a papule, then pustule, and then nodule, which will ultimately ulcerate. So important things are usually in PG pyoderma gangrenosum, it's a rapidly progressive ulcer and it is very painful. And it has a violaceous undermined edge. So these three things are very important. There are multiple variants of pyoderma gangrenosum. It can be a bullous pyoderma gangrenosum, when the patient develops a bulla and then which ultimately ulcerates. It is usually associated with hematological malignancies. Then we can have is granulomatous pyoderma gangrenosum, which is usually a superficial variant. And this is, it looks like any granulomatous disease, like we can give differentials of lupus vulgaris in this particular case. Then the next variant is pustular PG pyoderma gangrenosum, which was seen in our case. There is parastomal pyoderma gangrenosum, which is usually seen in obese individuals and after ileostomy or colostomy. And then there's one rare variant is vegetative pyoderma gangrenosum. The prognosis with vegetative pyoderma gangrenosum is good. It is usually not associated with any systemic illness and usually responds very well to treatment. So there's a criteria for pyoderma gangrenosum. As I mentioned, rapidly progressive, painful ulcer with violaceous undermined border. This is the most important thing. And three main differentials which we have to rule out in a case of any case of pyoderma gangrenosum is vasculitis, infection, and malignancy. So these three things we have to rule out. Then there are certain minor criteria also, like the pathology test, and then this characteristic cribriform scarring. It looks like a cigarette paper, and it's a cribriform scarring. And the associated systemic disease, as I mentioned earlier, the M, R, and I. And then the histopathological finding will find dense neutrophilic infiltrate and a rapid response to systemic steroids. Usually the rapidity is like we can assume almost 50% improvement within 1 month. However, we have seen in certain adult patients there may be response within a week also. So how do we approach a case of pyoderma gangrenosum? Firstly, a detailed history is required, or any drug intake, any trauma, or any systemic involvement. Then we carefully examine the patient for the ulcer, like what is the size, shape, and location of the ulcer. And if you're thinking of pyoderma gangrenosum, then we have to do a biopsy. The role of biopsy is usually not diagnostic, but to rule out other differentials, because it is usually non-specific histopathological finding in pyoderma gangrenosum. So we'll basically investigate in 3 lines, as I mentioned: vasculitis, infection, and malignancy. So all these investigations, it's a busy slide, but then all these investigations ultimately ruling out vasculitis, infection, and malignancy, because usually pyoderma gangrenosum is a diagnosis of exclusion. And then once we are through with our diagnosis, we can classify into various groups, because as I mentioned, bullous PG is mostly associated with blood malignancy. And then we can have classic ulcerative type and vegetative, which is usually a good prognosis. Now, the management is usually in severe cases, we may give a steroid pulse or we may give oral steroids. That depends on the clinician. And then other ways of managing are, we can give cyclosporin also. And adjunctive therapy, usually what we give is Dapsone is preferred. It's a wonderful drug for neutrophilic dermatosis. And I have used Dapsone and MMF. I have never used rest of the drugs for pyoderma gangrenosum. So Dapsone is usually preferred because it's not an immunosuppressant. It's a good steroid sparing agent for maintenance therapy, basically. Then biologics are also coming in way for pyoderma gangrenosum. And if you see mainly the TNF alpha blockers and the newer ustekinumab. So etanercept is like FDA approved for 4 years and above. We can use adalimumab again, 4 years and above can be used. And ustekinumab is around 12 years and above, it can be used. So these 3 biologics may be tried in pediatrics, but I don't have any personal experience with this. Thalidomide, as it's a TNF alpha blocker, it can also be used. And in refractory cases or in cases where you're suspecting that there's an overwhelming infection, then in that case, IVIG can be used in a dose of 2 gram per kg per cycle. It is usually to buy some time till the time you decide on to the definitive management. And of course, wound care is a non-adhesive dressing. Sterile saline dressing can be used. Silver sulfadiazine can be used, and hydrocolloid dressing. Basically, if the wound is oozing, then we can use hydrocolloid dressing. It also keeps the wound moist. That is also keeping the wound moist is also very important for ulcer healing. Then alternate therapies, skin grafting can be used, but the thing is, the disease should be quite at the time you're doing skin grafting, because then it can lead to pathergy, again pathergy phenomenon, because if we operate in an active disease. And then hyperbaric oxygen can be used. Other therapies which have been mentioned are topical nicotine, sodium chromoglycate, and apheresis. I'm not really sure about these therapy. I've seen only skin grafting and hyperbaric oxygen. Now, there are certain unresponsive cases, like especially this autoinflammatory syndrome, PAPA syndrome. So PAPA syndrome, having pyoderma gangrenosum, we can use anti-interleukin-1 antibodies. The canakinumab and anakinra are the drug of choice in cases of PAPA syndrome. Then there's also report of pyoderma gangrenosum with polycythemia vera. As we know that polycythemia vera has JAK2 mutation, almost 90 to 95% cases have JAK2 mutation. So JAK inhibitors like ruxolitinib has also been tried in some rare cases of pyoderma gangrenosum associated with polycythemia. Now, PG in children is rare. Almost only about 4% of the cases they appear in children. And the youngest patient which has been reported in is 3 weeks old neonate. Systemic illness are more common in children. Almost 74% of the cases can have some associated systemic illness. It can be malignancy, rheumatoid arthritis, or inflammatory bowel disease. So IBD, inflammatory bowel disease, is more common. It is again more common in adults, so it is the same as in adults and children. And pathergy, there are more chances of getting positive test in cases of children, as we got in our case. So this is just tabulate in the table form. So morphology, usually children may present with pustule as the initial lesions, whereas adults usually present with the papules. And site, as I mentioned, genital and perianal regions are slightly more common in children as compared to lower extremities in adults. And then IBD is again common in both. Usually adults have arthritis also equally. So this is some of the images which I've taken from internet. This looks like a classic ulcerative form of pyoderma gangrenosum, the first one. And this on the right is that children 3 weeks old, and you can see the amount of damage, and especially this perianal and this inguinal genital region is involved in this children. This child was treated with prednisolone. He recovered well. So these are my references before I move on to the next topic. So that's dermatomyositis. Yeah, so dermatomyositis, it's an autoimmune disorder. Predominantly, it is derived from dermato means skin and myositis means muscle. So it mainly involves skin and skeletal muscle. And patient may have variable involvement of internal organ. So the umbrella term is idiopathic inflammatory myopathies. IIM, it includes dermatomyositis, polymyositis, inclusion body myositis. So Bohan and Peter were the first one to give this classification in 1975. The problem with Bohan and Peter, which is relevant for dermatologists, is it does not entertain about a subset which is known as clinically amyopathic dermatomyositis, wherein you have all the skin findings of dermatomyositis, but you don't have any muscle involvement clinically or on investigations. So Bohan and Peter requires clinically a rash of dermatomyositis, proximal muscle weakness. On investigation, evidence of myositis on biopsy, muscle biopsy, EMG, or enzymes. So incidence, as you can see, as compared to adults, it is quite rare in children, 1 to 2 cases per 10 lakh. And the usual age group in children is 7 to 8 years. And in adults, it is almost 50 to 60 years. Females are slightly more predisposed, but this difference is very well this in children. It is almost 5 times females are more affected than males, and African American ethnicity are slightly more predisposed. And the risk of malignancy, that's where the significance of diagnosing this condition early. Almost 30% of the adults can have associated malignancy, but this associated malignancy is not very common in children. So this was the particular subset I was telling, the clinically amyopathic dermatomyositis, wherein you have all the characteristic features, cutaneous findings of dermatomyositis, but there's no muscle involved. Sontheimer was the first one to describe, called it dermatomyositis, sign myositis. Sign myositis means there's no myositis. So you have biopsy confirmed cutaneous findings of dermatomyositis. If they're present for at least 6 months, and there's no evidence of muscle involvement, then you label it as clinically amyopathic dermatomyositis. But nowadays we have 2 subsets of it. It can be amyopathic or it can be hypomyopathic. So amyopathic means skin findings, and apart from this, no muscle enzymes, no muscle weakness. Hypomyopathic means skin findings and no muscle weakness clinically, but on extensive evaluation, you do find some abnormality in the muscle enzyme. So that's when you label it as hypomyopathic. So in this particular subset, CADM, anti-MDA5 antibodies are quite common, and they also are more predisposed to develop interstitial lung disease and cancer. So pathology, pathogenesis, I've just tried to simplify it. So basically, the text which is highlighted in red, that is the most important point. So there is humorally mediated microvasculopathy. So microvasculopathy means it involves the muscle capillaries and the arterioles. So capillaries and arterioles are the small vessels, microvessels. So what happens is the initiating event, which we don't exactly know, leads to activation of complement system. So complement system, then the terminal complement complex, which is C5 to C9, it gets deposited onto the walls of the vessel, which leads to inflammation. Then it leads to ischemia, infarct, and hypoxic injury, which leads to atrophy of the muscle fibers. So gradually what happens is the capillary density goes down, and that's what you see in nail fold capillaroscopy, that capillary density goes down, and then there is compensatory giant capillaries can also be seen. And then also normally the membranes of muscle fibers, they're not supposed to carry this HLA1, but this in cases of dermatomyositis, HLA1 is upregulated on cell membranes of muscle fibers, which is not normally present. And then there are B cells, T cells, macrophages, and dendritic cell, and then which produce antibodies, which can be myositis specific or myositis associated. Now, the reason for differentiating these is because myositis specific antibodies like anti-Me2, TIF1 gamma, and MDA5 and SUMO antibody, these may be associated, these may actually be correlated with the clinical course and severity also. And associated antibodies, they're usually non-specific, may also be found in other connective tissue disorders like anti-Rho, UNRNP, PMSCL, and anti-COO. And also there is the anti-Jo1 antibody, which is again a myositis specific antibody. It is usually seen in anti-synthetase syndrome, which is again a subset of dermatomyositis. This upregulates type 1 interferon gamma production. And this type 1 interferon gamma again is expression, there is increased expression in the muscle tissues, which again lead to inflammation. Now, histopathology is often subtle, is not specific. What is most common is you see lichenoid infiltrate in the lesions, like especially if you do it from Gottron's papule or if you do it from any of the rash, a lichenoid reaction with basal cell vacuolar degeneration and occasional Sivart bodies may be seen. In early cases, you may confuse it with subacute lupus erythematosus, but the differentiating point is early stages of dermatomyositis will have immense amount of dermal edema. Later stages, because of fibrosis and all, it can resemble scleroderma. And apart from lichenoid infiltrate, Gottron papule can have hyperkeratosis, acanthosis, papillomatosis. Now, DIF is not very specific, but then it may be positive in almost 50% of the cases with IgM, IgG, and C3 deposits. This is histopathology which I've taken from Roots. In this case, you cannot really appreciate lichenoid reaction. It is not very well seen. And then I'll just my point. Yeah. So you can see some vacuolar changes over here. This portion, you can see some vacuolar changes. And then this is what is very sparse amount of perivascular lymphocytic infiltrate. This is also perivascular lymphocytic infiltrate. And here you can see this white gaps in between the collagen fibers. So this is what is early lesion of dermatomyositis showing dermal edema. So the collagen fibers, they separate. And if you do a biopsy from muscle, again, like there was perivascular infiltrate, here we get perifascicular infiltrate. So there is ultimately perifascicular atrophy. Because of inflammation, there is endothelial cell swelling. And then the C5 to C9 deposit can be seen on the vessel wall, and it leads to capillary necrosis and infarct. And HLA1, which is not supposed to be present, it is upregulated. And then, of course, the B cells and T cells and rest of the cells can be seen. There are classical cutaneous features of dermatomyositis. We'll see them one by one. So heliotrope rash is almost pathognomonic of this dermatomyositis, which is a confluent violaceous macular erythema, maybe lilac in color, usually involves the upper eyelid. If the disease is very active, you may see edema. So that is most commonly misdiagnosed by the GPs as angioedema. So they usually refer to us with angioedema. So if you see erythema and edema, it may signify that the disease is active. And this heliotrope rash can extend to rest of the face, like cheeks, nasolabial fold, and then forehead, neck also. This I've taken from internet. This is a quite very well demarcated heliotrope rash. It is very rare to find this kind of well-defined rash. Usually we see this kind of rash, just a faint erythema over the upper eyelids. It's a lilac erythema. This case we published in DPC. This is in skin of color. This is actually very difficult to diagnose in skin of color because it resembles like a post-inflammatory hyperpigmentation. And this lady had got severe disease, severe dermatomyositis. You can see the rash over over the eyelids, rash extending onto the nasolabial fold. This is one of the differentiating features with SLE, because in dermatomyositis you can get SLE this like rash also, but usually if the involvement is there of nasolabial fold, it goes more in favor of dermatomyositis. It can involve the forehead as well, and it can go on to neck as well. And then we have the V-neck sign, which is nothing but the photoexposed area. The patient will get, usually it's a poikilodermatous rash. Poikilodermatous rash means you have hypo and hyperpigmentation, atrophy, and telangiectasia. So in skin of color, you usually require dermoscopy to look at erythema and also telangiectasias. And in cases which the disease is very severe, you can get these kind of ulcerations also. So this is shawl sign in a shawl distribution. Again, a poikilodermatous rash, hyperpigmentation, atrophy, and telangiectasia. And this is our case, which is Gottron papule, and this is what you see in a skin of color, like getting hyperpigmentation. And then there can be streaks of hyperpigmentation along the tendons, extensor tendons, which is known as Gottron sign. So whenever you have this kind of lesion over elbows and knees, it is known as Gottron sign. And Gottron sign, as per the new Euler ACR criteria, it has got actually more weightage as compared to Gottron papules. This is Gottron sign in skin of color. You see hyperpigmentation over the knees. And then inverse Gottron papules, this is again quite rare to find. We found it with the help of dermoscopy. And then we have this mechanic hand, which were not seen in our pediatric case. So mechanic hands are nothing, but these are non-inflammatory callosities. Like Gottron papules and everything, they are inflammatory, but mechanic hands is, these are all non-inflammatory callosities, which would be found on the radial aspect of fingers or even soles. And then this is Holster sign, is when you see a rash over the lateral thighs. On dermoscopy, the typical finding is this Sammet sign. Sammet sign means cuticle would be ragged. There would be a ragged cuticle and there is hypertrophy of the cuticle. And then because of the damage and infarct, you can see cuticle hemorrhage. You can see dilated capillary. That's because of rest of the capillaries goes down. So there's compensatory dilated capillary loops. And then because of infarcts, you see intervening avascular areas. This is from an adult patient. She was a case of dermatomyositis with SLE. So you can see these dilated capillary loops, and then here this is capillary dropouts. So this was an advanced case. So capillary dropouts you gradually see over a period of time, and then these giant capillary loops can be seen. Now calcinosis cutis, this is more commonly seen in pediatric age group, maybe presence out of fingers and over the extensor surface. Now there can be vasculopathic phenomenon. Vasculopathy versus vasculitis is, vasculitis is when you have immune complexes and you have surrounding inflammation. Vasculopathy, there's only immune complexes, but there's no inflammation as such. So manifestations of vasculopathy can be livedo reticularis, ulceration, or telangiectasia. So this rash here in this particular dermatomyositis case, this could be a severe dermatomyositis rash can ulcerate, or even it could be a vasculopathic phenomenon, but vasculopathic phenomenon is usually seen over extremities. Then other less common findings, as can be seen in any connective tissue disorders, is mucinosis. You can have some pigmentary disorders. Ichthyosis can be seen. Rarely you can have vesicles also, and erythroderma also. Now, systemic involvement in dermatomyositis is mainly heart, respiratory, and GIT. Most common is lungs. So interstitial lung disease may be seen in almost 20 to 40% of the cases. And it may lead to respiratory muscle weakness, which can predispose to aspiration pneumonia, and ultimately pulmonary fibrosis and pulmonary hypertension. In heart, it can lead to conduction abnormalities, as was seen in our case, first degree heart block. And then you can have myocarditis also. And gastrointestinal, because of the involvement of muscles of upper esophageal sphincter and oropharynx, there can be dysphagia to solids and liquids. And then the electromyography findings, the ones highlighted in bold, they are quite typical. And spontaneous fibrillations, because these are dying muscles, and then positive shock waves and bizarre high frequency discharges are quite specific, as was seen in our case. Now, this is the latest Euler ACR criteria for specifically for inflammatory, idiopathic inflammatory myopathies. So the patient meets the Euler ACR classification criteria. If the classification criteria actually involves nothing, but it is quite similar to Bohan and Peter. Basically, you should have some muscle weakness, a rash, then muscle enzymes, and biopsy. And if the patient is less than 18 and you see heliotrope rash or papules, Gauthron papules, or a Gauthron sign, either of these, then you can simply label the patient as juvenile dermatomyositis. I'll not go into the adult part. So how do you evaluate a patient? First is, of course, a skin biopsy. So basically skin and muscle, these two things we have to investigate. Skin biopsy, and then in muscles, we do muscle enzymes, specifically CPK. Then rest of the enzymes like LDH, aldolase, AST can also be raised, but CPK should be done. And then in muscle, after enzymes, we do muscle antibody, myositis specific antibodies, of which anti-Me2 is usually found more, which is specific antibody and usually associated with typical cutaneous features. And anti-Jo1 is seen in anti-synthetase syndrome. ANA positivity may be seen in almost 80% of the cases, but usually the titers are very low and they're not significant. And imaging, apart from EMG, we do MRI to see muscle edema, and to also, if you want to go ahead with muscle biopsy, then it also helps localize the site of muscle biopsy. Wherever we see maximum muscle edema, we do biopsy from there. And then ultrasound, chest X-ray, we have to rule out any underlying malignancy, solid organ malignancy. And for GIT involvement, we do a manometry. And then if we find any abnormality in chest X-ray or any pulmonary function test, we can go with high resolution CT scan of the chest. And for cardiac involvement, we do echo and ECG. And for ruling out malignancy, we can do tumor markers and we can do colonoscopy. Stool for occult blood is also very important. This is the antibody profile, which we see. By just seeing at the antibody profile, we can actually make out like what's the, where to go. It actually gives us a direction in which we have to evaluate the patient. Like in anti-Me2, that's when you see hallmark cutaneous finding. All your cutaneous signs, heliotrope, rash, and everything will be associated with anti-Me2. And if you get anti-TIF1 gamma or anti-NXP2, the ones highlighted in red, they're usually associated with increased risk of cancer. So that's when you have to aggressively evaluate for any underlying malignancy. And then we have this anti-MDF5, which is associated with amyopathic variety, and also vasculopathic ulcers. They also have this MDF5 more. Then anti-Jo1 is also very important because it is anti-synthetase syndrome, wherein you see those mechanic hands and this very high risk of interstitial lung disease. And this anti-SUMO antibodies is again associated with skin. Now, to differentiate between these, juvenile dermatomyositis, usually the risk of underlying malignancy is low as compared to adults, where it is almost 30%. Calcinosis cutis, as I mentioned, it is more common in children. And this calcinosis, it may involve diffusely any of the extremities also, wherein we can call it as an exoskeleton. So it's an extensive encasing type of calcinosis with the limb or any part becomes stony hard. And then this acquired lipodystrophy may be seen, which is general partial focal. Anti-Jovan is less common in children. It is more common in adults. And anti-TIF1 gamma, as I mentioned, is associated with malignancy in adults, but in children, it is usually associated with ulcerating skin lesions. Then there are various severity scores. Like PASI in psoriasis, we have DSSI in dermatomyositis, which is dermatomyositis skin severity index. So we look at 4 main areas for redness, induration, scaling. Then for activity, myositis activity, we have MyoAct, and for myositis damage, we have is MyoDam. And then complications is, as I mentioned, respiratory failure, aspiration, pneumonia. If your muscle of this GIT system goes, then dysphagia, you can have malignancy, heart involvement may lead to cardiomyopathy, and there is accelerated atherosclerosis, and also psychological complications can also be there. And interstitial lung disease may be seen in almost 20 to 40%. So it is very important to evaluate these dermatomyositis cases for lung involvement. And then slightly higher mortality is seen in dermatomyositis as compared to polymyositis. And the most common cause of death is cardiac disease, almost 15 to 64%. Rest of the cases, death can be maybe due to respiratory disease or malignancy. Now, the prognosis is usually the patient requires long-term immune suppression. We can remember it, almost 30% have monophasic illness, 30% have relapsing remitting course, and 30% have almost chronic continuous course. But the most important is long-term immune suppression is usually required in these cases. 10-year survival is almost 90%. So treatment is basically, if you have severe disease, you can go for pulse steroid, or you can start with oral steroids at around 0.5 to 1 mg per kg. And then for long-term maintenance, we use these disease-modifying anti-rheumatic drugs, usually which is methotrexate, which is favored. And then IVIG is usually in refractory cases, or when you want to buy some time, or you have some particular contraindication for other steroids, and in that case, IVIG can be used. And for calcinosis cutis, we use calcium channel blockers and topical sodium thiosulfate. Now, second line is MMF. Mycophenolate is also quite underutilized drug in dermat, but it's a very safe drug. It's usually not favored in children. And if it is skin limited disease, you just go ahead with potent topical steroid, and you can add hydroxychloroquine. Now, in children, usually we prefer initial prednisolone dose of 2 mg. Instead of 1 mg, we prefer higher doses, 2 mg per kg. I'm not sure of the reason. I didn't find any explanation for this, but then this is a slight difference from adults. We usually prefer 2 mg per kg. And then methotrexate is usually the maintenance drug, which is preferred in children. MMF is not used routinely in children. However, it is very safe drug in adults. And IVIG rituximab can both be used. There are fewer emerging therapies in dermatomyositis, like JAK-STAT inhibitors. They're finding their way in almost each and every disorder, and similarly apremilast also. So these are all based on case reports and case series. Rituximab is very well established, and we've also used in adult patient of dermatomyositis. JAK-STAT inhibitors can be used, apremilast phosphodiesterase 4 inhibitors, and the biologics like interleukin-1 and interleukin-6. They're also finding its way, but these are all case reports. So I'm done. Thank you so much.
Thank you to both of you. They were absolutely brilliant talks. Have you got some questions for the audience?
Yeah. So I've just kept a small quiz of just 5 questions. So I'll start with the first question. You can just mark it, and I'll show the answers at the end. So I'll flash my 5 questions initially, and then I'll flash the answers. So which of these is not commonly associated with pyoderma gangrenosum? Acute myeloid leukemia, inflammatory bowel disease, Hodgkin's lymphoma, rheumatoid arthritis. So we'll just keep it at around 10 seconds, and then I'll move on to next question. So next question is, which of these gene is mutated in PASH syndrome? PSTP-IP2, PSTP-IP1, PTP11, PTSP1. The third question, what is the commonest age of onset of juvenile dermatomyositis? 1 to 5 years, 5 to 10 years, 10 to 15 years or 15 to 20 years. Fourth question, which is the commonest antibody which is found in clinically amyopathic dermatomyositis? It is anti-TIF1 gamma, anti-NPX, anti-MDF5, or anti-Jo1. Yeah, so the last question is, which of these is responsible for causing vessel wall inflammation and hypoxic injury to muscles in a case of dermatomyositis? Is it C2 to 4 complements, C5 to 9 complements, C3 complement, or C5A complement? Yeah, so I'll just flash the answer. I hope all of you have got almost 100% marks. So the most, which is not commonly associated, is Hodgkin's lymphoma. So we usually see malignancy, which is hematological malignancy, and then we have rheumatoid arthritis, and then IBD. MRI is the mnemonic, which I had mentioned. Then the most common gene, which is mutated in PAS syndrome, which is one of the autoinflammatory syndrome, is PSTP-IP1. And the commonest age of onset is usually 7 to 8 years in case of juvenile dermatomyositis. So 5 to 10 years is a good option. And the most common antibody which is found in clinically amyopathic dermatomyositis, where you have all the cutaneous findings but no muscle involvement, it is anti-MDF5. And then the most important thing which leads to vessel wall inflammation, hypoxic injury in dermatomyositis is the terminal complement complex, which gets deposited onto the wall and cause inflammation. That is C5 to C9 complement. Yeah, thank you so much. Thank you so much.
Thank you very much, both of you, Dr. Kothari and Dr. Kishore. They were fascinating talks and a lot of information, so the quiz was good to go over it. Let me just share my screen once more. And here we go. So now I will hand over to my co-host, Ucheche Julie, and she's going to run through some questions. So if you pop them into the comment box now, and she will ask them to our speakers.
Thank you, Emily. The first question is to Dr. Karthi. Can the size of the lesions in the first case be said in centimeters? Sapo grain is not universally known, so we cannot all really use it for estimation of the size.
Thank you for the question. Actually, we had used the terminology sago grain because we generally describe the presenting complaints in the language of the patient. Otherwise, it was more or less ranging somewhere less than a centimeter or somewhere between 1 to 2 centimeters. I would say that it was not more than that.
Okay. And to Dr. Kothari, how is juvenile dermatomyositis different from adult dermatomyositis?
I think I have answered it in my slide. I have kept the differences. So usually, basically, just to revise, so usually malignancy is not very common in juvenile, and then of course, rest of the differences, as I mentioned, we prefer higher doses of prednisolone initially, 2 mg per kg, and then MMF is usually not preferred in children, and lipodystrophies are quite common in children. Calcinosis cutis is quite common in children. And also the interpretation of antibodies like anti-TIF1 gamma, if we see in adults, it is associated with malignancy, whereas in children, it is associated with more of ulcerating disease. So these are the differences.
Okay, thank you. The next question is, what is the best treatment for calcinosis cutis in the setting of dermatomyositis?
Yeah, as I mentioned, if it is not very extensive, like you have just 1 or 2 lesions, we can simply excise them. or sodium thiosulfate topical. Usually if you want to give just topical agents, and if it is very extensive, then we go ahead with diltiazem, which is a calcium channel blocker. But I have not personally used diltiazem. You can use, usually there are just 1 or 2 lesions, so we can simply excise them. That's
Okay. How was monkeypox ruled out in the first case?
we did not rule out monkeypox because these cases, they were almost 1 year old. Back then, monkeypox was not there, so we didn't was there in our differential. So.
Okay, and the next question is, was there a chance it was secondarily infected with monkeypox?
I'm not really sure about secondary infection with the monkeypox virus. We did think of bacterial infection. That's why we had given antibiotics. Child also had fever for 10 days. So we, as per our hospital policy, we do give gram-positive, negative, and anaerobic cover. So that's why we had kept a possibility of secondary bacterial infection.
Okay, that's all for now. We encourage attendees to keep to send in more questions to the speakers.
So if that is everything, does anyone want to put any more questions in the chat at all? Otherwise, I think thank you very much, everyone. I think we will leave it there for today. I don't think we've got any more questions. So I just want to say a huge thank you on behalf of the GloDerm Trainee Committee to Dr. Kothari and Dr. Kishore for, oh, have we got a question or is that something else? Oh, it's a thank you, good. For giving us your time today. They were really interesting talks. And also thank you to my co-host, Icheche, and also thank you to the rest of the GloDerm committee and the ILDS for helping make this happen.